Our next presenter is Dr. Mafalda Oliveira of the Vall d'Hebron University Hospital in Barcelona, who will present GS302, camizestrant, a next-generation oral SERD versus fulvestrant in postmenopausal women with advanced ER-positive, HER2-negative breast cancer, results of the randomized multi-dose Phase 2 SERENA-2 trial.
Thank you so much. Good morning. On behalf of my co-authors, I would like to thank the opportunity to present today the first results of the randomized Phase 2 SERENA-2 trial. These are my disclosures. Camizestrant is a next-generation oral selective ER degrader and pure ER antagonist. SERENA-1 demonstrated the safety, tolerability, and preliminary clinical efficacy of a range of doses of camizestrant as monotherapy with dose-dependent exposure. And SERENA-2 was designed to explore the efficacy and safety of a range of camizestrant doses administered once daily as monotherapy in comparison with fulvestrant, which is the current SERD standard of care. SERENA-2 is a randomized, open-label, multicenter Phase 2 trial that included postmenopausal women with ER-positive, HER2-negative advanced breast cancer candidates to receive fulvestrant monotherapy. Other key selection criteria included recurrence or progression on at least one line of endocrine therapy, no prior treatment with fulvestrant or other oral SERDs for advanced breast cancer, no more than one line of endocrine therapy or chemotherapy in the advanced setting, and presence of measurable or evaluable disease. Patients were stratified by prior use of CDK4/6 inhibitors and by the presence of lung and/or liver metastases, and randomized to receive camizestrant at 3 different doses, 75, 150, and 300 milligrams, or fulvestrant. The protocol was amended in December 2020 to close the arm of camizestrant 300 milligrams after 20 patients were included. And this decision was due to strategic reasons in the absence of toxicity concerns. The primary endpoint of SERENA-2 was progression-free survival, as assessed by the investigator by RECIST 1.1 criteria. Secondary endpoints included clinical benefit rate at week 24, overall response rate, overall survival, and safety. And translational endpoints included serial CTC and ctDNA analysis, including ESR1 mutation tracking. SERENA-2 was designed to compare each of the camizestrant doses with fulvestrant. It was not powered to compare camizestrant doses with each other. As the enrollment to camizestrant 300 milligrams was stopped early, no formal analysis of camizestrant 300 versus fulvestrant were conducted. 108 events for the pairwise comparison versus fulvestrant provided 86% power at the two-sided 10% significance level, assuming the true hazard ratio was 0.59, and the median PFS in the control arm was 5 months. Primary analysis, triggered in August 2022, used a stratified Cox proportional hazards model to compare PFS, adjusting for prior use of CDK4/6 inhibitors and presence of lung and/or liver metastases. And no multiplicity adjustments were made for multiple comparisons in this Phase 2 study. Between May 2020 and August 2021, 240 patients were included in 75 centers across Europe, America, and Asia. Most patients were white, had ECOG 0, and a median age of 60. And per inclusion criteria, all patients had ER-positive disease. As planned beforehand, half of the included patients had received prior CDK4/6 inhibitors. Lung or liver metastases were present in 58% of patients at baseline. ESR1 mutation was detected in 36.7% of patients overall. This proportion was slightly higher in patients receiving fulvestrant. Overall, 20% of patients had received chemotherapy in the advanced setting. And all patients had been treated and progressed to prior endocrine therapy. 67% of them had received prior adjuvant endocrine therapy, and 69% had received endocrine therapy in the metastatic setting, the vast majority an aromatase inhibitor. And let's move now to the efficacy results. SERENA-2 met its primary endpoint. In the overall population, camizestrant produced a statistically significant and clinically meaningful improvement in investigator-assessed PFS for both 75 and 150 milligram doses over fulvestrant. Adjusted hazard ratio for the 75 milligram comparison is 0.58, with a statistically significant p-value of 0.0124 and a median PFS of 7.2 months versus 3.7 months with fulvestrant. Adjusted hazard ratio for the 150 comparison is 0.67, with a statistically significant p-value of 0.0161 and a median PFS of 7.7 months versus 3.7 months with fulvestrant. In the subpopulation of patients previously treated with CDK4/6 inhibitors plus endocrine therapy, camizestrant at both doses produced a meaningful improvement in PFS over fulvestrant. Hazard ratio for the camizestrant 75 comparison with fulvestrant was 0.49, with median PFS of 5.5 versus 2.1 months, and the hazard ratio for the camizestrant 150 comparison was 0.68, with median PFS of 3.8 versus 2.1 months. In the group of patients with no prior CDK4/6 inhibitors, hazard ratios for the camizestrant 75 and 150 milligram comparison with fulvestrant were 0.78 and 0.65, respectively. In the subpopulation of patients with lung or liver metastases, camizestrant at both doses produced a clinically meaningful improvement in PFS over fulvestrant. Hazard ratio for the camizestrant 75 milligram comparison with fulvestrant was 0.43, with median PFS of 7.2 versus 2 months, and the hazard ratio for the camizestrant 150 comparison was 0.55, with median PFS of 5.6 versus 2 months. The benefit of camizestrant in the group of patients with no lung or liver metastasis was less apparent. In the subpopulation of patients with detectable ESR1 mutation at baseline, camizestrant at both doses also produced a clinically meaningful improvement in PFS over fulvestrant. Hazard ratio for the camizestrant 75 comparison was 0.33, with a median PFS of 6.3 versus 2.2 months with fulvestrant. And for the 150 milligram comparison, hazard ratio was 0.55, with a median PFS of 9.2 versus 2.2 months. Among patients with no ESR1 mutations detected at baseline, the magnitude of benefit was smaller, but still hazard ratios also favored both camizestrant as 75, with an hazard ratio of 0.78, and 150 milligrams with an hazard ratio of 0.76. For this analysis, we defined ER-driven disease in accordance with the 5th ESMO ABC guidelines for secondary endocrine resistance, but increasing to 12 months the cut point for progression for patients receiving CDK4/6 inhibitors in the first-line setting, as opposed to 6 months for those receiving endocrine therapy alone. In the subgroup of patients with evidence of ER-driven disease, which represented 71% of the whole population, both camizestrant 75 milligrams and 150 milligrams produced a clinically meaningful PFS improvement over fulvestrant, with hazard ratios of 0.53 and 0.58, respectively. Median PFS for camizestrant 75 was 7.4 months, for camizestrant 150 was 12 months, and for fulvestrant 3.2 months. In the small subgroup of patients without evidence of ER-driven disease, the benefit of camizestrant over fulvestrant was less clear, but still the hazard ratio for camizestrant 75 compared to fulvestrant was 0.73. Treatment with camizestrant 75 and 150 reduced the level of ESR1 mutation ctDNA to undetectable or near undetectable levels by cycle 2, day 1, and maintained these to cycle 7, day 1. Fulvestrant also reduced levels of ESR1 mutation ctDNA, but not to the same extent as camizestrant. A blinded independent central review of tumor scans was performed as a sensitivity analysis and also showed a statistically significant benefit in PFS at both doses of camizestrant over fulvestrant, consistent with investigators' assessment. Hazard ratio for the 75 milligram comparison with fulvestrant was 0.56, with a median PFS of 7.4 months versus 3.7 months, and the hazard ratio for the camizestrant 150 comparison with fulvestrant was 0.47, with median PFS of 12.7 months versus 3.7 months with fulvestrant. Objective response rate and clinical benefit rate at 24 weeks also favored camizestrant at both 75 and 150 doses over fulvestrant. The clinical benefit rate at 24 weeks was around 50% in both arms of camizestrant. In the next two slides describing patient safety, data from the 20 patients treated with camizestrant 300 milligrams are also included. Overall, treatment-related adverse events of grade 3 or higher were infrequent across treatment arms. Only 2 patients discontinued treatment due to an adverse event. Those interruptions were infrequent and of short duration, and those reductions were also infrequent. Treatment emergent adverse events that occurred in more than 10% of patients in the camizestrant arms were photopsia, sinus bradycardia, fatigue, asthenia, and arthralgia. The vast majority of cases of photopsia and bradycardia were grade 1 events, and again, grade 3 or higher treatment emergent adverse events were very infrequent across the arms. Overall survival maturity at data cutoff was 24.5%, and follow-up and later analysis is planned. And additional upcoming analyses include detailed assessment of intersections and interactions between key subgroups, as well as analysis of the rich translational data set, including serial ctDNA and CTCs. So in summary, SERENA-2 met its primary objective. Camizestrant at both 75 and 150 milligram doses improves PFS over fulvestrant in postmenopausal women with ER-positive, HER2-negative advanced breast cancer. Camizestrant delivers statistically significant and clinically meaningful PFS benefit at both 75 and 150 doses over fulvestrant in the overall population, and a clinically meaningful PFS benefit was observed across the pre-specified subgroups of unmet medical need: post-CDK4/6 inhibitors, patients with lung or liver metastases, the population of patients with emergence of ESR1 mutations, and evidence of ER-driven disease. Both camizestrant doses are well tolerated, with infrequent grade 3 or higher treatment-related adverse events, dose reductions, and discontinuations. So in conclusion, the results of SERENA-2 support the further development of camizestrant in ER-positive breast cancer and recruitment to 2 phase 3 studies of camizestrant in advanced breast cancer, SERENA-4 and SERENA-6, continues. So I would like to thank all the patients and their families for their participation in this trial, all the investigators and site staff around the world for their invaluable contribution, and please scan this QR code to view a plain language summary of this abstract. Thank you for your attention.
Thank you very much, Dr. Oliveira, for your presentation. One quick question. What dose of the camizestrant is being used in the phase 3 studies?
A great question. So a decision was made looking at the data that came from the SERENA-1 study to go forward with the 75 milligram dose. And the reason for that is that there was a relatively flat exposure efficacy relationship in terms of overall response rate and PFS. So that's the dose that is currently on use.
Okay. Thank you very much. We have time for a couple of questions. There's someone at microphone 3.
From Adelaide. My question follows on from that one, because you did say that there was a dose-response relationship in the early part of your talk. One of the main reasons fulvestrant never really took off was because it was dosed too low in the early stages of its development, but you've dropped the highest dose even though there was no increased toxicity signal. I just wondered if you've got anything more to say about that.
Yes, thank you for your question. Perhaps I was not clear before. So what we saw is that there was no dose-response relationship.
Okay. Thank you. Thank you again, Dr. Oliveira. We have to move on.
Thank you.